Welcome, thank you for listening to my presentation. Today I will present my abstract about previous urethral endoscopic procedures and pre-operative self-dilatation and the risk of stricture recurrence after urethroplasty. My name is Yildirim and I'm a medical doctor and PhD candidate from the Netherlands. We declare no conflict of interest. I will guide you through my presentation with these slides. First, some background. Endoluminal procedures such as urethrotomies and urethral dilatations are the first-line treatment for urethral strictures. It is known that the risk of recurrence is high with these procedures, especially after repeat endoscopic treatments. Over the years, urethroplasty has emerged as a viable option for recurrent urethral strictures. The aim of our study was to analyze if previous intermittent self-dilatation and number of prior endoluminal treatments increased the risk of recurrence after first urethroplasty in men with penile-bulbar urethral strictures. All patients between 2011 and 2019 with first urethroplasty were selected from a prospectively gathered database with standardized follow-up protocol. Only patients with bulbar strictures or penile-bulbar strictures with a short penile extension were included. Penile-bulbar strictures with a penile approach were excluded, as well as patients with a history of prior urethroplasty, hypospadias correction, or pelvic fracture. It was our aim to create a homogeneous patient population. The primary outcome was the risk of stricture recurrence after first urethroplasty in relation with the number of prior endoscopic treatments or performance of ISD. Stricture recurrence was defined as any need for re-intervention indicated by both patient symptoms and diagnostic findings. Univariate and multivariate analysis were performed. In total, 106 patients were included, with a median follow-up of 12 months. Re-intervention was necessary in 16 patients. There are some interesting findings which I would like to discuss here. First, we found that recurrence was more prevalent in patients with 3 or more prior endoscopic treatments, with a risk of recurrence of 28%. There was no increased risk with 1 or 2 prior endoscopic treatments. Furthermore, we found that prior performance of ISD increased the risk of recurrence after urethroplasty. We also found an association of prior performance of ISD and number of endoscopic treatments, as 61% of the patients with 3 or more prior endoscopic treatments performed ISD as well. Multivariate analysis showed that ISD and number of prior endoscopic treatments were no independent predictors for recurrence. Concluding, we found an increased risk of recurrence in univariate analysis with 3 or more prior endoluminal procedures and prior ISD after first urethroplasty for penile-bulbar urethral strictures. In multivariate analysis, they were not identified as independent risk factor. This can be explained by the high prevalence of ISD in patients who had 3 or more prior endoscopic treatments. We did not find a relation to recurrence after first or second endoscopic treatment before first urethroplasty. Our study suggests that there might be room for a second endoscopic attempt, though patients should be well informed about the high recurrence risk of a second endoscopic attempt opposed to the high success chance of the more invasive urethroplasty. Based on our results, we would strongly advise against a third or more endoscopic treatment for recurrent urethral strictures. Thank you for listening. If you have any comments or questions, you can leave them behind.